Community Hospital in Florida.
So we usually record these and put them on our website, if that's okay with you.
Yeah, that's totally fine.
Okay, and if you have slides and all, you know how to run this thing, right? The share screen and all.
Yeah.
Okay. So,
Do you want to give it a few more minutes for anybody else?
I think we're okay for now. You can. Why don't we get started? Okay.
Okay, sounds good. Just give me 1 second here. Okay. Can you guys see my screen?
Yes.
Okay. All right. I'd also like to mention I have Dr. Biniak, who's one of the participants. She's our program director, so she's here as well. All right. So yeah. So ONMM. So it's osteopathic, stands for osteopathic neuromusculoskeletal medicine, pain and addiction, and I kind of wanted to bring these three fields and or specialties together because me being board certified in ONMM, I had the experience of doing a lot of pain medicine in my residency as well, and now that I'm currently doing addiction medicine, I kind of see that I found a way to kind of put them all together, and I use them, all three specialties together to kind of do the best for my patients. And so I just wanted to share a little bit about what I do kind of day to day, and everybody here is probably more experienced than me, so I'm here to learn, and maybe I can spread a little bit of more about what I'm doing, and maybe you guys can learn something from me that and that's basically my main goal here today. So just starting off, I want to dive right into it. So what really is addiction? And so there's a lot of definitions out there. There's addictions for different things, but one way that we can kind of bring it together is if you go to the American Society of Addiction Medicine, the board of directors adopted this definition in September 2019. So they say that addiction is a treatable chronic medical disease involving a complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction they use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. And then prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. So a few key points over here that I want us to just keep in mind is that addiction is, as per the definition, it is a treatable, it's a chronic medical disease. And there's a lot of factors that contribute to one's addiction. And so, just like it's incorporated in the definition, patients who have mental health disorders, who have environmental factors, and that can be beliefs and attitudes of one's family, interactions, between certain peer groups, and then genetics. We see that, someone who is, for example, currently an alcoholic may have an uncle who was an alcoholic. We kind of see that a lot. And then another risk factor is, somebody who starts using drugs at, a very young age. So these are all different, factors that can help basically help us, that tell us, that define the addiction of that patient. And just a few things to keep in mind here. And so, on this diagram on the right, I want to kind of go into each little aspect of it. So there's the initial use, and then there's the abuse when you when you use the substance the way it's not recommended. And then I really want to get into like the tolerance, because tolerance can be confused with dependence. And so tolerance is basically, it refers to the body getting used to a substance, and when it requires and it requires higher doses. So basically, you need more of that substance to make you feel this the same way. So that's your body telling you it is tolerant. And then dependence, we need to make a very clear distinction from tolerance. It basically refers to a physical or psychological symptoms that occur that make someone feel like they must continue taking that substance. And so basically that person is dependent on that substance, otherwise they get symptoms if they don't have that substance. So that's kind of the distinction between dependence and tolerance. And then that kind of feeds its way into addiction. So addiction is basically, it's a behavior in a nutshell. And it's basically when a person is unable to stop using a substance, even though he or she knows the negative consequences or the risk associated with it, but they just have to use it, and it becomes a behavior and a lifestyle. So that's kind of what the difference between addiction and dependence is. And then addiction can lead to relapse, and then from there the cycle kind of starts all over again. Okay. And so if you wanted to talk about what addiction is, um, an interesting way that I found out about that someone explained to me was during one of the conference at the American College of Addiction Medicine that we went to a few weeks ago. And the presenter kind of said that if you look at the synaptic cleft, that pretty much is where all the addiction takes place. You know, there's addiction has to do a lot with the neurotransmitters, and a lot of the activity of the neurotransmitters takes place in the synaptic cleft. For example, one of the major neurotransmitters in addiction is dopamine, serotonin, glutamate, endorphins, GABA, just to name a few among the many different ones. And so um, basically addiction can be described as, you know, a balance of the neurotransmitters. We have inhibitory transmitters, and then we have excitatory transmitters. So the inhibitory are usually like the GABA, and then the excitatory usually like the glutamate. And so if there's an imbalance in these neurotransmitters, that can lead to, you know, certain changes in physiology, either in the brain or in the body. And, you know, there could be things that happen, for example, such as seizures, epilepsy. You know, this is usually due to an imbalance in these neurotransmitters. And so just want to talk a little bit about the neurotransmitters that I've listed. And so like dopamine is one of the biggest neurotransmitters in addiction. It plays a huge role in our bodies. You know, it influences learning, concentration, memory, and it's mostly known for our body's reward system. And so, you know, having adequate amounts of dopamine is essential for our physical, mental, and emotional well-being. A good balance of it is good for the body. And then cocaine, for example, I want to list some substances that affect the neurotransmitter. So cocaine disrupts the imbalance in the dopamine largely. And the serotonin is basically known as the happy chemical. It contributes to feelings of like well-being. It also helps regulate the mood and sleep-wake cycle. And you know, hallucinogens play a key role in the serotonin neurotransmitters. A lot of patients that, you know, we see with who use hallucinogens, they're usually, you know, very happy and, you know, very like calm and kind of cool. That's kind of the personality we see in patients who use hallucinogens. And then glutamate. Glutamate is one of the most important neurotransmitter of the for normal brain function. Like I said, it's an excitatory neurotransmitter, so it plays a huge role in the excitatory part of our brain. And so, you know, it's also involved with learning, fine and gross motor skills, And that's why we see, kids with ADHD, they lack these functions. And so that's why, we give Adderall and amphetamines are kind of like the drug over here that affect glutamate. And then, and I just want to talk a little bit about GABA. So GABA is really important because it's really affected by alcohol. And we see a lot of alcohol use disorder in our program, in our patients, almost on a daily basis. And, GABA is basically the neurotransmitter that causes sedation. It's an inhibitory neurotransmitter. And so, it's good for, everything has a role in the body. So GABA can be good for, to help, with sleep, people who have insomnia. So, we can, if you give them some GABA, they'll be able to relax and help their sleep. It helps with anxiety and it helps reduce overall excitability. Again, that balance that we talked about. However, if you drink too much alcohol, it can overstimulate the GABA pathways, and that causes the extreme sedation of the central nervous system, and in turn can cause alcohol toxicity and overdose. And so in patients that have continued exposure to alcohol over time, it can desensitize the GABA receptors. And then to a point, they become so desensitized that people they feel like they have increased stress and anxiety, which makes them want to drink even more, and it becomes a cycle because the receptor is so desensitized that if you take away the alcohol, it just causes a severe imbalance in the excitatory and inhibitory pathways of the brain. And so I want to dive a little bit into what osteopathy is. So, I'm sure this is an osteopathic board. So we all know osteopathy was founded by Andrew Taylor Still in the late 1880s, and we often hear that osteopathic medicine is a holistic approach to medicine. And so that's what it is. It's a whole person approach to hands-on care. We are the highest professionals that provide hands-on treatment and management. And so some general concepts, with osteopathy is that it is the medicine that sees, um, different systems of the body and how they relate to each other, and how we can use different modalities, different techniques to allow the body to heal itself. So that's one of the main points of osteopathy, is that the body is able to heal itself. And so we must remove the restrictions to allow the body to do just that. An example that I thought about was that if we get a cut on our bodies, the body heals the cut. So if there's imbalances in our brain or changes in our brain, we have to allow the brain to heal itself. So it kind of falls under the realm of osteopathy, that we could allow the body to heal itself, whether it's a physical manifestation or even a psychological or from addiction standpoint. I'm going to get into this in a little bit. I just first want to talk about what pain is. And so pain is also one of those definitions that, there's different ways it could be defined by different sources. But just generally speaking, and I just want to keep things very general, is that pain is usually, when we think about pain, it's usually has to do something with a physical impact. Like if a patient, a lot of times patients are in a car accident, there's a physical trauma to the body, and now they have pain, and now they develop chronic pain. Or if you stub your toe, we know that there's chemicals going back to the brain, and then synapses that make you feel the pain from a physical cause. But what I want to get more at in this lecture is that pain can also be mental and it could be emotional. And in those terms, pain, a lot of times what it is suffering. And in our patients, we see a lot of suffering that these patients have been through. They've been through a lot of trauma, um, emotional, mental, verbal trauma in their early lives, and they carry that with them over time, and it causes chronic suffering, which leads to substance use, addiction, and so I kind of want us to focus more about the mental and emotional aspect of pain. And so, acute pain versus chronic pain. So usually acute pain, depending on what resource you look at, could be anything that's less than 3 months or less than 6 months, because some sources say chronic pain is anything that pain that lasts anywhere from 3 to 6 or more months. And so one of the ways we can look at the differences is by looking at the symptoms. And so in patients with chronic pain, a lot of times we see very tense and stiff muscles. And in osteopathy, we kind of say TAR changes, tissue texture changes. So someone with chronic changes will have really tight, stiff changes in the body. They have limited ability to move around, once again, due to the stiffness over a long period of time, a lack of energy and changes in appetite. And then emotional wise, chronic pain can lead to depression, anger, anxiety, fear of the re-injury itself. Usually this is seen in, athletes, veterans, and it can really, limit the patient's ability to return to work or do something that they enjoyed doing if I got injured while doing it. And so I want to go back to this chart that I made. Basically, here I'm leading a pathway towards addiction, and so I started listing the different ways that we manage pain. And so pain, as we know, can be managed by prescription drugs, like opioids. It can be managed by over-the-counter drugs like Tylenol, NSAIDs. It can be patients use illicit substances to manage their pain. And then there's also non-pharmacological methods. Some of the non-pharmacological.
What?
Should I make some more for you? How many more do you want?
Can you guys hear me?
Sorry about that. We're good.
Yep,
Good?
we can hear
Okay. Perfect. Yeah, so I want to focus on OMT because that falls into the non-pharmacological methods. Well, one of the non-pharmacological method to treat pain. And then the other ones that we know about that are common are like nerve blocks, physical therapy, neurostimulation, comfort therapy, psychosocial therapy, and that kind of falls back into like the risk factors that patients can have, coming from poverty or different peer groups.
January, you get 9 days.
And so that's why that kind of falls into the non-pharmacological method. And then I categorized substance use as those methods where pain usually isn't controlled. So if pain isn't controlled by opioids from a prescription drug, it can lead to substance use. If a patient's pain isn't controlled by Tylenol and Advil, they can look at other avenues to control the pain. And so once you do have use of any substance, your pain can be either controlled or not controlled. And usually when the pain is controlled, you allow the body to heal itself, and then you go towards recovery. But if there's inadequate control, it can easily lead to substance abuse. So you can go from using a substance that is not controlling your pain, which can lead you to abuse that substance because you're just in so much pain and you just need something to make you feel better. And as we can if you look in the green box, we have the different risk factors that we talked about. There's genetic factors, psychiatric. There's a huge overlap with psychiatry in this field. And so we always have to keep that in mind. The patients who do have a psychiatric illness or psychiatric component, they're higher risk of developing substance abuse. And then socioeconomic risk. These are all things that can lead to substance abuse. And then once you're abusing something, that can lead you down the road to addiction. So a little bit about chronic pain. There was a study done in 2016, and estimated that about 1/5 of the US adults had chronic pain. And so this is a pretty big deal, first of all, because it's 2016, and now we're over 6 years past that time. So it only went up. But that's basically saying that every one in five people that you meet is dealing with chronic pain. And that means that they're dealing with either physical, emotional, or mental pain um, that they've been dealing with for at least 3 to 6 months. And so, like we mentioned earlier, chronic pain, it leads to so many different things down the road, not immediately, but usually down the road. It affects relationships. It affects families. It can break down families. We see a lot of our patients who not only are homeless, but they've lost contacts with their siblings and their parents and their other family members, and they don't have contact with them. And usually this is a chronic thing. If you're and then chronic pain can lead to anger, frustration. So just imagine if your pain isn't controlled by something that your physician is prescribing, it can lead to anger over time, and that can lead to hopelessness and disturbances in your career. And if you're fatigued because you have this pain that you can't do anything, it's um, making you incapable of performing, your day-to-day activities. You're just going to feel hopeless and depressed. And then you have insomnia because you have so much anxiety and you don't know what to do. And so it really has a domino effect in terms of, um, you know, psychological issues and mental and emotional suffering that these patients exhibit. And so this is just a general summary that we talked about, that, you always want to make an assessment. You want to always prescribe, we want to keep non-opioid options in mind first, and then opioid options. And then you always want to assess, at each step, in this field, like you have to weigh the risks and benefits. You have to keep in mind that, okay, if I want to prescribe um, medicine to this patient, I have to keep in mind that it may benefit him, even though it's a opioid agonist, for example, methadone, but it's going to prevent them from overdosing on the drug and killing themselves. So there's always risk and benefit at each step, and we always have to weigh our options in terms of management of the pain. And so, we come back to the question, can OMT really help with pain? There's a lot of research that I found, and it's not one-sided at all. There's a lot of studies that, support OMT in terms of pain management. There's a lot of research on OMT and low back pain. So there's research that supports the thesis of OMT does help reduce pain, but there's also a lot of research against it. And so, we, if anything, that tells me that OMT is not really going to, it's an option to have because you can help a lot of patients, and the worst thing that can happen is you don't help them. But if you do help even just one more person, that's a really big deal, because that could be one more person that you delayed in prescribing the opioids and them overdosing on it. And so there was a systematic study in 2005 um, that showed a systematic review of low back pain, and it was treated with OMT, and it found that OMT significantly reduces lower back pain. Um, and this is something, and in the study, they had consistent OMT implemented. It was several times a week over the span of several months. There was another study in 2021 that looked at 22 different articles. And same thing, the OMT reduced the pain levels, improved functional status, it decreased medication usage. And so, it just shows there's a lot of articles there that do support this thesis. And there's definitely, you know, you know, good that's being done with OMT. Now, just diving into a few techniques that I want us to keep in mind is that a lot of patients in addiction medicine have a lot of mental illness, psychological illnesses, and one of the direct ways you can approach that in OMT is cranial OMT or craniosacral. And so, in osteopathy, we believe that, the cranial bones have movement. There's sutures and they move with the sutures. And so these patients a lot of times have a lot of cranial restrictions. And so doing cranial is one of the best ways that I've seen, I've seen improvement in terms of anxiety and stress in my patients. There's also myofascial release, specifically in the head and neck. Once again, these patients are very stressed, and when you're stressed, you kind of tighten up your traps and your shoulders come up, and so that's why focusing on the head and neck can kind of dissipate that stress, can cause relief in the tightness in those muscles, and and I'm sure everybody knows that if you get a neck massage, it really does make a big difference in your day. There's also suboccipital release, and I have some images of these in the next few slides. But suboccipital release is basically taking your fingers and holding it in the suboccipital area, and kind of just applying some pressure superiorly and with some traction towards you as the patient is laying on their back facing up. It creates gapping within the occiput, and that's one of the areas where by doing so you can relieve a lot of stress in the tissues. And so there was actually a study done about craniosacral treatment, and they use the treatment routinely at follow-ups, and the best way they found symptoms to be relieved in patients was continuously doing it, and the symptoms and the relief lasted for up to 6 months. And so these are just some images of how you can incorporate OMT. And so if you look all the way on the bottom, you can see some cranial techniques, the hands around both ears, fingers underneath the neck. You can put your hands on top of the head. And OMT is a very gentle technique. Generally speaking, OMT techniques are very gentle. And so if you just think about it, placing your hand on somebody for, let's say, about just 60 seconds, right? Without moving, without inducing much movement, it's a pretty good amount of time, And so your patient is just lying there and you have your hands on them for a couple of minutes. To them, it seems like the world has slowed down. Things are okay. And, they can even like feel themselves calming down. And like I said, it only takes a few minutes, but just having that physical touch on these patients who are usually always in a fight or flight mode, or are very anxious and are paranoid, just slowing them down. It just really giving them this physical touch really does make a big difference. So this is myofascial release. There was a study done that showed using myofascial release improved pain. It helped with sleep. And ultimately, if you sleep better, your quality of life improves. This is suboccipital release. So like I said, there's a lot of small muscles in the neck, really strong muscles. such as the rectus capitis posterior major, obliquus capitis superior, rectus capitis posterior minor, and obliquus capitis inferior. These are very small, very strong muscles that can really tighten up in these patients. And like almost every one of these patients, of my patients that I do suboccipital release on, they're just extremely tight. And I've seen tightness in this area a lot more in my fellowship than in my residency. And that just kind of tells me that, this is definitely one of the key areas to focus on in patients with substance use. And so can OMT really help with addiction? It really comes down to, the philosophy. We want to maintain homeostasis in in the synaptic cleft. And osteopathy is all about maintaining homeostasis. It's a key tenet of osteopathic philosophy. And so if we address the disruption in homeostasis, in dopamine homeostasis, for example, in patients who use cocaine, it could really play an important role in better understanding and ultimately treating these patients with their complex clinical phenotype. And so, osteopathic primary care physicians, we can identify patients in our practices that may have substance use disorder, and we can initiate treatment grounded in core osteopathic principles of treating the whole patient, not just specific symptoms or behaviors. And so some of the clinical goals with using OMT is using non-pharmacological options in our patients. And during my residency, I was very fortunate that we had a lot of options to do pain medicine as well. And so although we were occasionally prescribing opioids to patients who really needed it, we were always supplementing OMT. And that was like a standard. So if a patient came in, he was always getting OMT, unless it was contraindicated and they refused. But even the patients who were on opioid medications for years and years, due to, for veterans we had a lot of veterans who had injuries during war overseas, and patients with, crushing injuries and severe low back issues that couldn't even get surgery. So we always used OMT to supplement the opioids. And a lot of patients would always tell me that, OMT is one of the main reasons why they haven't gone up in the doses of the opioids. And I've heard a lot of times they tell me that I'm only on this low dose because I come every week or every other week and get OMT. And so, that's a big deal, because we all know the long-term effects, the chronic effects of opioids and how it can affect, daily life and the quality of life. And so the fact that we can just use hands-on treatment for a few minutes, a few times a month, can really help delay the progression of opioid use, delay the progression of pain, which has that domino effect of, depression, anxiety, and worsening quality of life. Like I said, there's a lot of research that says doesn't attribute OMT to relieving pain. And in that research, a lot of time what I found was that there just weren't enough participants. It wasn't a big enough study. So there's a lot more research that's needed with addiction and OMT. And so I think that's only going to come with time, but we have to start somewhere. And so in the hospitals, what I'm starting to do now is I'm actually starting to consult, my osteopathic O&M colleagues, and I tell them just do cranial. If they don't have a physical complaint, if their knees and hurting or back isn't hurting, just do some cranial sacral therapy on them, because just that amount of just a little bit of cranial sacral makes them a much better patient and easier to handle, easier to attack their anxiety, psychological diseases, and it's a great supplement treatment to have. And it all comes back to this chart, because if you can delay the time that substance use goes into substance abuse, and if we can go from inadequate pain control to adequate pain control with non-pharmacological methods, we're just delaying and pushing off addiction as much as possible. And that's it. Thank you so much, everybody.
Well, thank you, Dr. Abdul.
Excellent. That was very nice. I don't know if I get a list of participants. Hopefully, I can get CME credits for the DOs for this lecture. Thanks, Dr. Mizra. That was excellent.
Thank you.
You're welcome.
There's some way to get a list. Keep this list.
Yeah, just get me the list of the DOs. Thanks.
Okay. Anybody know how to do that?
Well, I took a picture of the participants, so
You got them all?
I'll
Okay.
work on it. I can handle it.
Okay, great. Okay, Dave, you have anything to add?
No, I just the combination of, having osteopathy in family medicine and osteopathy in substance abuse is just so ideal. I almost feel like AT still is looking down upon us and saying, "I told you so." I told you there was going to be an opioid epidemic. So he just fits right into our addiction fellowship, and I'm really proud of the progression that fellows are making. So,
So how many of these types of patients are you dealing with at a time?
well, we have addiction consult service. So there's 3 hospitals now. So these guys are working. I don't know. Sometimes we get up to 10 to 15 hospital consults. Most of the issues, so there's a lot of modalities we can use. Sometimes it's harder to, we're trying to have our efforts on retaining them when they, leave. But at least in the hospital, they're, hospitalizations can be a little shorter, and there's other modalities that we can, use to treat other than medication. So it's a good thing. It's a great combination.
What are you doing to sort of document that this is a legitimate way to go?
Well, a lot of our patients, as you heard, have addiction and pain, right? So,
Right.
We consult O&M on some of the pain patients, and they do some manipulation and document just like they do on any type of consult. So
Okay.
Yeah, and we're also looking at the length of stay, and documenting in like the notes. We ask them a pain scale, and we basically just get their feedback, after treatments, and see what kind of what they're thinking, if they've ever experienced such a treatment before. And so all these small little things, we're just starting to, but I want to continue this for the remainder of the fellowship and kind of see what patterns that it leads to. So it's a work in progress.
What kind of response are you getting from your non-DO folks, or those that are kind of skeptical?
Go ahead, Dr. Mizra. You have anything to answer there? We seem to be well accepted. Maybe because I'm a DO and Dr. Mizra is a DO, and so I just I think. Go ahead.
Yeah, the OMM consoles have been around for several years at our hospital, but this is like the first time that we're using it to supplement addiction patients. So all the other residents and fellows, they're quite familiar with the osteopathic manipulative treatment. They get consulted for any type of patient. If a patient has any GI disturbances, any other MSK pain, O&M is always being done in the hospital. But it never really was directed towards addiction patients. And so now we're using it in our detox unit a lot more.
Okay, there's a question in the chat that's a little bit off topic, but what kind of manipulation can help patients with neck stiffness and dizziness as a result of vestibular neuritis?
Yeah, so, for vestibular neuritis, I would certainly focus on the cervical, upper thoracic areas, and then the sacrum, for sure. The sacrum and the cranium, they're connected. And so the way I start off the treatment is I balance the cranium and the sacrum, one hand underneath the occiput, one hand underneath the sacral base. And I kind of just look at the pattern, the rhythm that the patient has, and try to balance that rhythm. And then that kind of tells me which one is more stuck, because if the sacrum is stuck, that can affect the occiput and vice versa. So it ends up leading to, working on the sacrum a little bit and then the cranium. But ultimately, also the cervical area, so a lot of myofascial, suboccipital release, all these soft techniques are very helpful. Balance ligamentous tension, just balancing the different planes of motion of the cervical spine is also a very good indirect technique. It's a lot softer and a lot more, convenient for patients, because myofascia can, if you apply some pressure, BLT doesn't have involve as much pressure. And so you could use a combination of direct and indirect, but I would stay away from the HVLA, which is a high velocity, low amplitude, which involves a thrust that could worsen the vestibular neuritis. So I would mostly focus on the indirect techniques and craniosacral technique.
Okay, I hope Dr. Fishbein, that answers your question. Back to your addiction service. Have you developed a protocol or a prescribed way to go for different types of substance abuses? So uppers versus downers, perhaps, or do you just look at the individual and see they got a subscapular T3 tightness and go for that? Is there anything specific for addictions and specifically for different types of substances?
That's a great question. Yeah, go ahead, Dr. Leskowitz.
That comes into play with, certainly some medications we use. So, the osteopathic is in conjunction with our medication. So let's just start out by saying all medications that are indicated for alcohol and substance use disorder are indicated for alcohol and substance use disorder with therapy, both, physical therapy and mental health therapy. So it just depends. So if someone's with opioids, we tend to use buprenorphine a lot, Vivitrol, but as far as specific body parts, that's separate. It just depends if they're addicted to cocaine, we may use some cross tolerance like Wellbutrin, if that, or I tried Adderall sometimes, but alcohol is standard, so not really. As if I'm trying to get to your question, as far as body part, that's OMT, and as far as what their substances is usually kind of how we go with what medication we use, but both get a combination, because most of our patients with substance use disorder complain of pain, or at least it started with pain, or they think they have pain and they really don't. So that's the story there.
Okay. So what kind of general OMT training, or is there anything specific, with in your program, Dave?
Yeah, so are you talking about the residency that I did?
Yeah, well, you did your addiction residency, right? But is there any specific OMT techniques, for what you're, we're going to use it exclusively for, or, first for what you're doing?
Yeah, so I would say that just in general with OMT, you always want to diagnose first. So depending on what the area you're trying to treat, in terms of what I usually do with on the addiction consult service is I usually start off in the head and neck and the sacrum. Those are kind of like my three go-to areas. And then so I diagnose and then I treat those areas. And that's kind of the way that we were taught in my residency. And that's how I'm implementing it into my fellowship. And so there's not really a particular protocol that I follow, but I think just generally speaking, for me, it makes sense for me to attack this area first. And then I know when I work on the neck, I have to on the head, I have to work on the sacrum as well. So that's kind of my mindset. It's mostly about balancing and finding good movement in the body. It is a patient vibe. Everyone is different. So some patients require more work than others. But ultimately there's no set correlate. It's kind of how I was taught in residency. Yeah.
Okay, great. Okay. Anybody else have any comments or questions or anything to add?
Yes, I have one. I'm Deborah Dell. In my practice, I was near an Army base, and I also had a number of veterans in my practice. And I found, number one, the patients that I found that had a lot of addiction problems, I always did a fairly complex family history, and I would see depression, alcoholism, suicide, depression in their histories. That was the number one thing. I saw a lot of PTSD, and in all of those patients and in addiction patients, I found that OMT was so helpful. Not only did it help them relax, and not only did it help them feel that someone else was on their side, and that and help them deal with their pain. It also would frequently bring up issues that they had, emotional or mental issues, PTSD issues that they had and hadn't realized that they had. And so I think that that's a wonderful idea to implement OMT with treatment for addiction.
Well said. Well said. I think you put your hands on a patient as opposed to just prescribing medications. Is it's what I've heard, and it's just so true. So true.
You bring up a very good point, Mrs. Dell, is that a lot of times when you're doing cranial osteopathy in these patients, you do tend to bring out past emotions, hidden traumas that the patient is suppressing. So those do come out quite often, if not to the full capability, but like a portion of that trauma. I see it all the time, and so it does help them. To them it's like a wow factor. Like they've never seen a hands-on treatment that can induce emotional release in a way. So that's definitely a good point. Yeah.
So a long time ago, I went through the UCLA acupuncture program, and they had some ear acupuncture techniques. Do you ever use any of those? Is that ever part of your protocols? It was also used for calming and sort of bring the patients into a state of
we're open to that. The addiction fellowship right now is just 1 year. I feel that soon it'll be 2 years as we add pediatric addiction, OB addiction, and I certainly alternative. We're very open to
Mhm.
anything other than opioids. So acupuncture would be, we have an elective. Nobody's chosen that yet, but I would certainly approve and certainly look to
Yeah,
you or
yeah,
who
so,
could take
I
one of
mean,
our.
yeah, I mean, it was in 1985, Dr. Michael Smith in New York City came up with this. It was called the NADA protocol, NADA, and it was auricular acupuncture for addictions. And
Yeah.
it's been modified slightly over time, but we use it all the time for all sorts of things here, in our
Well,
office.
that you'll be glad to hopefully get a resident or an addiction fellow. I hope, doctor, to spend a couple weeks with you. Then
Anytime, Dave.
We like your neck of the woods out there in Vegas. So, yeah, that'd be great. There you go, Dr. Misra. You're welcome.
Yeah, don't let him fool you, Dr. Misra. I'm 400 miles from Las Vegas.
All right.
So, okay. Anybody else have any comments or questions? That was very informative. It was great, succinct. We're going to let everybody get out of here at a decent hour for once. Next week we have a Mr. John Finnick who he's a psychologist in Reno, Nevada here, and at Lake Tahoe, and he does some integrative psychiatric work with biofeedback and some other techniques. So he's going to give us a little bit of insight on that. And hey, Dave, maybe there's something that you guys could use also.
Oh, for sure. We'll see you Tuesday.
So that's next week, same time, same station. I don't know what happened with the why we had trouble signing on tonight. I did the same thing I always do, and we were getting so sorry we got started a little bit late. I hope we didn't lose hardly anybody. We had an average crowd for us, so again, we admonish you. Anybody who's new, please leave us your email address there in the chat so I can add you to our email list. We're here every Tuesday at this time, 5 p.m. Pacific, 8 p.m. Eastern, and wherever you are in between. When you get our emails, there's still Stefan Hartman and Mr. Gonzalez are still working on that prostate program that they had presented, and there's there's another program on there too, and I forget what that was, for diabetes type 1 that we had, the keto diet study also. So if you're interested in that, the links are there on our email every week. Dave, thank you. Great as always. Dr. Misra, thank you so much for being with us.
Thank you for having me. I really appreciate it.
Please come back sometime. AOSRD.org/webinars. This is where all of our programs are. You can find the videos. A lot of them have transcripts also, and some of them have slides. But you can get all of the programs that we've had. We've been doing this for over 2 years. We've had quite a variety of speakers, and we've sort of built a tradition here. So thank you again, everybody. I know it's holiday time, and please be well, be safe out there. Anybody who wants to present anything, please let me know. And always, like I always ask you every week, please bring one friend so we can double our census here every week. So again, take care, Dave. Thanks as always. I will be bothering you again in the future.
No worries.
Mirza, you're always welcome. Please don't be a stranger. John, you got anything for us? Can't hear you.
All is good and very beautiful talk. Thank you.
We doing another convention this year, Bill? Before I let you work on.
I'm kind of on hold, as you know. We had a bit of a setback, and unfortunately, I've taken it rather hard, and I need a little space. So maybe by the end of the year, middle to the end of the year, I'll have it together. I mean, if you want to get it together, that's fine.
We'll talk.
But I'm a little bit burned out at the moment, and every time the subject comes up, I start seeing red and my blood pressure
Okay.
goes up. So
All right, well, we'll
I'm
talk.
trying to put it to rest. So,
All right.
but we'll do something. Maybe maybe
Tuesday.
just an online thing or something. We'll do
Sure.
something. Okay.
All right, thank
All
you
right.
very much.
Thank
Great
you, everybody.
presentation.
Thanks for being here. We'll have this up as soon as we can. Usually we have it up within 24 hours on our website. Next week, John Finnick, again, with some integrative psychiatric techniques. So we'll see you then. And if you know anybody who wants to give us a talk, is afraid to give a talk, we don't bite, only on Thursdays.
right.
Please let us know. So good night, everybody. Thank
Thank
you
you.
all. Thank you again, Dave. Thank you, Dr. Misra.
Thank you so much. Have a
Bye-bye.
good night.
Thank you so much.
Take care.
Thank you.